Yeah. Okay. Emeka is Robert from Nigeria, and I'll be sharing the Nigerian perspective of managing children with lower limb differences, local to global. Nice. Okay. Greetings from the National Orthopedic Hospital in Igbobi, Lagos. This is where most of the procedures of patients that will be seen on this presentation were managed, and the surgeries were done. It's a 450-bedded orthopedic hospital. It's the foremost orthopedic hospital in Nigeria, and it caters to all the population in Lagos, about 20 million, and the environs, and even from neighboring African countries. So quite a number of our patients present to our pediatric orthopedic clinic with one form of limb difference or another. Most of them are congenital and developmental cases, with a significant number of them presenting very late. This is one of the features in my environment. A lot of people present late because of cultural beliefs, bad advice, and financial restrictions. Then a number are caused by infection and infection sequelae. A high number of these present trauma with mismanaged fractures and soft tissue contractures, especially complications of trauma by the traditional bone setters, whose practices are still quite common in this environment because of the quite low number of doctors to a patient's population ratio. So some of these people try to fill in the gap, but they cause more damage than good in their management. So I'll be talking about this from my own perspective. There are quite a few number of limb reconstruction surgeons present in Nigeria, but we're growing by the day, and everybody has similar experiences, more or less. So until about 8 years ago, when there were quite very limited number of people that did quite complex limb reconstructions, especially in pediatric age group, a lot of these patients were left untreated or received suboptimal care because the conditions are quite complex in nature. The training and the skills were not present, and the resources to even manage them, even if the skills were acquired, were not available. Most of the companies that supply implants to the hospitals really don't supply these implants that can help in treating these deformities because of low demand. These are a spectrum of a few of the kind of cases that we see. We see quite a number of cases because my hospital is a referral center. So even all across the country, even any case that is quite complex comes all the way down to my hospital because that's where we have the high concentration of specialists that deal with these conditions. So we see almost everything in the literature. Even the rare things that are reported, once in a while we see them in my practice. A lot of them, facial injuries, neglected infection and sequelae with significant bone loss, skeletal dysplasia, trauma, all of them, they just come like that. So when I started out, I was quite determined to help these patients, but I pondered on a lot of things. Where and how do I get trained? How do I source for materials and implants and instruments that I will need to treat them, even if I get the training? And how do I get support from the hospitals? Because you can't do this alone. It's a multidisciplinary treatment. How do I get my colleagues involved? How do I get my residents to be interested and the operating personnel to tag along? So I just did the basics initially. I think it's something that is available. You can easily access books and that discuss these basic principles of limb reconstruction. And a few of these implants, we started organizing a few workshops here and there to introduce their implants, and we're able to learn a few tips and a few tricks from them. So we began with the multilateral limb reconstruction system. These are quite easy to apply because we have been doing external fixators, linear external fixators. So it's just to combine our knowledge of the principles of limb reconstruction or deformity correction and extraction of genesis with the skills we have in applying these external fixators. So, but these are limited. These have limited applications because they are the kind of deformities we see were really quite complex. That there are some limitations in some of the conditions that we need to treat. So I self-sponsored myself to Milan to meet with one of my mentors, Dr. Kirienko, who put me through the basis of Ilizarov fixation application. It was quite a wonderful experience. I also traveled to Sanchetti and Nakola to meet Dr. Chaudhry, who put me through as well, which is a array of cases. The cases in India are quite similar to the ones we have in Nigeria, so it was easy to really see the kind of patients I see back home being managed, and it was easy to import those skills with me back to when I came back. I had a lot of motivation actually, and I had a lot of interest. So that really helped along with learning these things. So from then, I had the evolution of my methods from the multilateral fixators to the Ilizarov ring fixators. Then later, as we'll see, onto hexapods. And then of course, combining all these combinations in achieving the necessary correction based on what presents to us. This is just a summary of where I've been. I've been to other places apart from this, but they were quite refreshing. So earlier in my practice, a few of the cases I did, applying a multilateral fixator for a child with some congenital femoral deficiency. Inherited to a problem too is quite a follow-up. Once a patient is okay, they don't come back to the hospital. For a lot, they don't even come back at all if they feel that they don't need to see you again. So it's difficult to follow up these patients to see. This case was done about 8 years ago. This child is about 12 years now, and I've not seen her since then. Every time I speak to the dad will tell me she's fine. So from then, we have begun to apply these fixators better. You can see the first picture was applied along the anatomical axis, but later we learned about anatomical and mechanical axis and how to improve on our applications. And subsequently, with further training and experience, we learn to combine with ring fixators so that we can do osteotomy quite close to the metaphyseal area to achieve a better regenerate, and then to prevent dislocation, especially in some significant limb length discrepancy. This was my first case of Ilizarov in my practice, which was already a case I'm happy with because the result was quite impressive even for me. So it was a child with a committed a chronic osteomyelitis of 2 years duration, who has had no treatment. It was just moving around with a modified improvised cat brace. And after I came back from Milan and I saw this child, I just went ahead to do this procedure, excised that dead bone and then did a bone transport. And this was the result. So I was quite impressive that even the leg that was reconstructed, which is the right, is even looking better than the left one. This child is in college now, is in university now, is doing very well. So from then, most of these cases are quite common in my practice too. A lot of osteomyelitis with bone loss. So some of them, the skin conditions were quite bad, and we had to combine our treatment with the plastic surgeons who, on raising a flap, we just put an antibiotic cement, antibiotic impregnated bone cement, just to give that, to create that membrane. We call it the applied musculate technique to enable us transport bone down. As everybody might know, it's quite difficult to get bone grafts from children, cancerous bone grafts from children. So instead of causing more morbidities, we just do a bone transport through this membrane. There's no fibrous tissue to interpose, and it just goes smoothly. And this has really been a way of treating these children, and the results are quite impressive. All of them have gone on to do very well and to heal very, very well. The one on the extreme right is a patient with a bone gap that I was considering. I just looked at the fibula that was bigger than the tibia. So just ended up destructing the entire bone and then did an intraperiosteal transport of the fibula to bridge that gap. This serves almost like a vascularized tubular graft. We didn't have microvascular trained personnel at that time. So that sounds more like a vascular graft because everything, all the muscles attached to that bone, all moves with it to provide a union, and the results that you see was quite impressive too. So severe Blount's disease is the commonest condition I see in my clinic. It's quite common, and a lot of them present quite late. So this was one of the patients I managed. Some of them have grotesque deformities. Even with the exuders, there's limitation to how much you can correct, especially torsion. Some of them have torsions that are as much as 45 to even 90 degrees. So imagine such torsions, you have to do multiple osteotomies then to reduce the treatment time. So we do a mid-tibial osteotomy and for acute rotation, and then a proximal osteotomy for gradual correction, which helps us to achieve the correction we needed. But all that has changed now, as we'll see later. So this is a child with a congenital arthrosis too, the ones I treated first, that had multiple surgeries, actually came from a neighboring country, Benin Republic, and came with this picture. So I just removed the implants, freshened the edges. Unfortunately, this child didn't have any fibula. Even then, a cross union, as described by Dr. Paley, wasn't possible in this child, but the child had a very good result. The bone healed, he had not had any fracture. This child was treated about 5 years back, and had made good progress. The same problem we have, they have failed to come back for follow-up. Even the screw I put in the medial physis to try to correct that ankle valgus, I don't know what's happened to it, because the child didn't come back for follow-up. But right now, what we do, still with the problem of getting adequate bone grafts for bridging that, for causing that cross union, we take an opposite fibula, and break it up into bits, and stick it between the tibia and the fibula of the tibio-arthrotic limb, and then also take the little bone graft you can harvest from the iliac crest. So I've done that in like 3 patients. Unfortunately, they are still undergoing treatment, but the results I'm seeing are quite impressive. So one can actually use that if you can't get adequate bone graft to help in achieving that cross union that helps to prevent a hip fracture. So this is a case of Olier's disease. They all just come like that. All these cases were treated at one time or the other, but they keep coming back. And then we did a lengthening deformity correction, both tibia initially, and then while waiting for the rear to mature, we now did the femur as well, which eventually gave a good result for the child. This is a polio limb hypoplasia too, that we managed, that gave us impressive results as well. And the concussion band syndrome, this child had problems walking, can see the callosity in the lateral aspect of the foot and the heel because of walking difficulties with significant limb length discrepancy. So this child was managed with an Elizarov fixator and achieved relatively good results as well. And the child can walk well. Still, the child is since 2020, it is 2023. I've not seen this child since then. So it's a real big problem in my environment. Okay, this is a 15-year-old child with a very severe Blount's disease. You can see the scarring on her limbs because she has been to the traditional bone setters multiple times without any improvement. She has very poor skin quality, and you have to do the same, do a mid-tibial dilatation, and then osteotomy of the proximal tibia for gradual correction. It give a good result. So we have lots of support from individuals, societies, and organizations who saw our work and our efforts. I'll just mention the LLRS, Limb Lengthening and Reconstruction Society of North America, the Science Surgical Network, and the IGOT, who has really helped us along the way. They are giants that we've stood on their shoulders, that held our hands and taught us, because they help us with trainings and mentorships. They augmented our work with supplies of frames and implants, quarterly seminars, meetings and webinars that helps us to review our work and even improve on them and share what we learned from what they know and can pass across to us. We also collaborate with other local limb reconstruction surgeons who have been to other places, to Egypt, to India, to Portugal. From the experiences we gain, we collaborate a lot and then talk about cases and look for the best way to treat them. So these are a few of my mentors and teachers. This is my LLRS and traveling fellowship. I went to Ohio, Baltimore, to Philadelphia, to Dallas. I met all these wonderful surgeons who were very generous with their knowledge, with their time, and with the efforts and everything that helped us to go along the way. Apart from that, we had the SIGN Circle Network organizing Train the Trainers workshop. They actually came to my hospital to train us on the use of the hexapods. And this was a game changer with all the knowledge we gained from the meetings at the LLRS, IGOT, and SIGN. The group of surgeons who are actively involved in limb reconstruction were taught on basics of the hexapods, and this was really a game changer for us. So we didn't really need to do multiple osteotomies for these complex deformities because the hexapod will correct most of them. Though we still need to have some tricks to apply to correct some of these deformities with the hexapods, but they really did help us along the way to treat very severe deformities. This is a case of Bardet-Biedl syndrome, a very rare condition that happened in two sisters. But because of the business, we didn't have the required frame, but SIGN came to our aid and helped us with frames that we used to manage these patients, she and her sister, and they did quite well. So how do we apply this? How have we gotten along? Since it's been difficult to actually to get travels, fellowships, trainings since COVID happened. It's just now that things are getting better. So in that period, we had to establish a limb reconstruction unit in my hospital, pediatric and adult, and that has helped us to even learn more and collaborate better. Then the residents' rotation through the units have improved, and a lot of them have developed interest in limb reconstruction as well. Clinical attachment and visitation from other surgeons from other hospitals has also helped them to start some form of limb reconstruction in their centers to reduce the load on one center. The local fellowship opportunities have been commenced. In my hospital, we offer a 3 to 6 months fellowship for people to learn about the basics of limb reconstruction, to help them manage some of the patients that can't be managed, and the ones that are quite complex can always be referred or collaborated. We've also had to travel also to other centers to participate in surgeries. When they pull patients together, we just take off a week or two and go and aid the surgeons to perform surgeries within the country. That has also helped in skill transfer. And of course, there's no way you can work without incorporating the people that work with you, the ORPs. They are the ones that hand you the implants. They need to know about them. The physical therapists for post-op, pre and post-op care, the nurses, radiologists or radiographers, patients and caregivers, very important, because in most of these treatments are gradual correction. So you need intelligent parents that will know how to turn these bolts and nuts the way you want them to, or the struts. But we found a way of teaching the patients themselves, and they seem to understand it better even than some of their parents. And this has helped in achieving the results they desire. So generally, a good clinical judgment is required, and selection of cases that are suitable to managing these complex reconstruction options, and a good detailed preoperative planning, case reviews, and discussions with experts in the field are things that will help us along. Patients' high motivation and commitment is very important. Some of these cases are long, prolonged. Patients come, call you, send you messages at times about pain and other things, about pin tracts, infection. So one needs a high level of patience, commitment, and motivation to actually help them to cope. Readiness to invest time as well, money and resources to train and skills acquisition. But if I and my colleagues have not invested our personal time, personal money and resources to this training and skills, we'll probably still be at the same level we were more than 8 years ago. So that has really helped in helping us with our patient motivation and commitment. So then, of course, readiness to train and work with other people is very important, which helped us to achieve our desired thing too. So,
Mika, I'm sorry, you're a few minutes, over time. So can we maybe? Okay, I know you're almost done. I'm sorry to interrupt, but for the sake of timekeeping, is that okay if we do the rest during your discussion? Is that okay?
It's okay. Just a slide. That's all.
Yeah, sure. Okay, yeah. Awesome. Okay. Thank you so much. Okay. Really appreciate it. So much. Yeah, no, our pleasure. This is great.